Hello, everybody. We will get started here once everybody comes in from the waiting room.
Recording in progress.
Let me just test out one thing real quick. All right, I think we are ready to go. Let me go ahead and share. Great. All right, everybody. Hello, and welcome to our friends from around the globe. I'm Nikki Medina, Director of Education here at SIIM, and will serve as today's moderator. Welcome to this month's webinar, How to Put Patient Outcomes First in a Rapidly Changing Breast Imaging Landscape. Thank you once again to Barco for their sponsorship of the 2022 SIIM webinar series. This webinar is eligible for 1 hour of SIIM IIP credits that can be used for SIIM members towards your ABBY CIIP certification or recertification. As we go through the webinar, we want to encourage you to ask your questions using the icon in the Zoom menu. We will answer all questions at the end of the presentation. So today, we would like to welcome Albert Zathona, Senior Product Manager at Barco. He has an international experience in displays, medical physics, and strategic marketing. He is a member of the American Association of Physicists in Medicine and the Society for Information Display. Albert is an author of publications and has patents in the field of perception and display technology. He holds a BSE degree from Princeton University. Help me in welcoming Albert Zathona.
Thank you. Thank you. All right. So I will share my screen here. And all right. So you can probably see that.
Looks good. Let's get started. Thank you.
All right. Thank you for joining. And so today I'm going to talk about, how we can take advantage of the rapidly changing landscape in breast imaging to really advance things for patients, but also with an eye towards the practitioners and what's involved for them, what makes the difference for them. And so we're going to talk about clinical productivity innovations, how these define the future of breast imaging, a little bit about how to get the same quality and comfort as that you have in the hospital in your home, and then get into some of the regulations that impact the diagnostic imaging team, and really the answer there being the remote QA and display fleet management. So with that, let me go in here. Great. So digital breast tomosynthesis, this has been growing quite rapidly. Like a lot of new modalities, it started out with different trajectories around the country, but now it is really completely one of the normal modalities that's used for breast screening and also diagnostic exams. And so we see how that growth occurred. It's basically an example of a successful new technology that's introduced into this. The other thing that, alongside that, you have like the concept of the Breast Imaging Center of Excellence. And so the ACR put this together and basically says, well, you have to have, mammography in one form or another, it can be 3D or 2D, that's accredited. You have to be able to do stereotactic breast biopsies, you have to be able to do, breast ultrasound and breast MRI. That the last one being like something you can refer people to a place that knows what they're, knows what they're doing and will, integrate with you. Now, interestingly, I was looking back, and in 2016, it was only 10% of the facilities that had this, stamp on them, and it's now the majority. So this is something that maybe not everyone decided they were going to do at the beginning, but quite rapidly everyone decided you don't want to be without this as a facility. So taken along with tomosynthesis, these modalities bring rapid diagnostic capability to the participant who's coming for breast screening, and then potentially getting worked up. And then that in turn means that we have multimodality, workstation requirements, and that a lot of these images are going to go off to the PACS and come from there when they're being reviewed. And what does it mean? And it's like, well, we're going to need not only grayscale accuracy but also color accuracy, because some of these modalities use color. And people are going to want to visualize these in one place. So if you have, the traditional mammography exam, that maybe used to be displayed on a grayscale monitor, in order to put it in one place, you either want to get another screen really close to it, or ideally get it all onto one screen, so that you can compare easily back and forth across modalities. And then of course people want to be able to do their diagnostic work on the same workstation as they're doing their screening. And I'll mention an exception to that when I get to the section about home reading. But here's an example of from real life, about combining the modalities. And Dr. Margarita Garza, she is someone who is definitely, leading the way and looking at even the modalities that aren't mainstream, molecular imaging, and was an early adopter of MRI for breast imaging. And her point is that she wants to have everything on the same screen. She wants to make the comprehensive diagnosis from the same screen, and then she can get this done in a matter of minutes. And I think for how long it takes to perform the work of coming to the diagnosis varies a lot, of course, per case. But I think it's easy to see that if you can get it all onto one thing, that's the opposite of half of it is over on a workstation over there, and half of it is on this dedicated screening workstation here. So I think this is a good example of what people are facing in real life, where it would be nice if you could get it all onto one screen. And before I go on and talk about some of the small advantages that one version of the hardware has over another, or what have you, I really want to talk about screening in general, and why is it so challenging? Why is mammography screening a special case in radiology? And it really comes down to the nature of screening. So here I have in this chart two populations. One is healthy, one is diseased, and those are denoted by the green being the healthy ones, and the ones with evidence of disease being the ones in red. And then we have some tests, and what the result of the test is going to be is how they appear, meaning how they appear in that test, with the result of that test. And so then plotting it in the vertical direction, it's how many people appear that way. So it's a histogram, basically. So with this particular screening test that I'm using as an example, it's a poor test, right? There's an overlap in the appearance between the healthy population and the diseased population. And so when people decide, how am I going to operate? How am I going to judge who needs to come back for additional work, who can, we're going to presume is healthy and tell them they're okay. I have to pick up an operating point and, how they appear and draw a line there. And if I pick point A, then I am certainly catching most of the diseased population, leaving out a little bit, but I'm catching most of them and bringing those people back for workup. But I'm also bringing back a substantial chunk of the healthy people on the left-hand side, of that curve there. So everyone has to decide where they're going to operate. Someone else might say, oh, I hate to bring people back, when it's unnecessary. So they would have a much stricter appearance. They would wait for something to be much more suspicious. And maybe they would operate at point B. But we can see that's very impractical because they would, leave out, they would fail to bring back, most of the diseased population. So that's, again, this is a poor test. Sadly, this is also about what mammography screening looks like today. We have to bring back actually quite a few people in order to catch the diseased population. So here's another test. This is a great test, by comparison. It has much more separation between the healthy and the diseased population. And so it would be relatively easy for someone to say, well, I'm going to operate at point C, and you'd be pretty happy with how that impacts society, but also how many of the people you're going to, diseased people you're going to catch. And this basically, the other way we refer to this is we say it has fewer false positives, it has more true positives, and it's a higher curve on an ROC plot, right? So this is, the better screening test, which brings me then to what's the motivation here. The image quality has a positive impact on the tests, right? If we have improved equipment, it increases the separation between the healthy and diseased people. And it doesn't, lots of things are going to affect this, right? It's the quality of the modality, how well tuned up it is, the quality assurance that's being done on it. It's the workstation, display system, how conspicuous. It's also the training of the radiologist. So all of these things serve to, as they improve, they serve to pull these two populations further apart in terms of how they appear. And that's the motivation for even small changes, because you can see that even a small change would have potentially a substantial impact on the way this shakes out in terms of who gets called back. All right, so if we look at the history, and I'm not going to go through all of this, but you can see that we've been at this for quite a while from the Barco standpoint. It's about 1996 that we started to get involved. And when people were first developing digital mammography, in fact, it was with scanned films at the very beginning with our involvement. And then this moved on and digital tomosynthesis was introduced. And this caused people to have multimodality workstations, that had to be able to handle moving images as well as the 2D, but also people were at the same time adding more and more use of the ultrasound and MR. And more recently then, we have the home reading workstations. And that's something that actually probably started in 2019, that some people were taking and setting things up in their home. But of course, in 2020, this accelerated greatly. So now let me turn to the technical challenges that happen with breast imaging displays. And I'm not going to go through every detail of what makes good image quality for these, but I just thought a couple of examples of this will be helpful in thinking about it. And so if we look at the challenges, the first one is stability, like how things behave over time. And one of the things that makes medical displays unique is that they've been initially derated so that they can compensate for the aging effect. So we could deploy something that was brighter initially, but then it would fade over time, as shown in the little picture there on the left. But the problem with this, very quickly, people realized when PACS started, is that doctors will quickly learn which is the good one, which is the new one, and then they'll say, "Oh, I want to read my cases on that one that's brand new, and the one that's older, I don't want to use that one." That's one problem, but the even larger problem is that the degradation is very gradual. And so you have a problem where people are satisfied with it today. Tomorrow, it looks essentially the same. And every day thereafter, compared to yesterday, it looks the same, but it's slowly getting worse and worse and worse. And so you get to a point where years later, it looks horrific, and no one has really noticed it until they see something else, or someone comes and looks at it who is familiar with something else. So that stability is the first thing that is very important in the medical displays. And then, of course, you have other things that have to do with the image quality. So the brightness, the uniformity of that brightness, we want to be the same all over the screen. So it doesn't matter whether we bring up an image, over on the right-hand side or in the middle of the screen. The color consistency, this is a more recent concern with the more and more use of color and subtle colors, so that it's not just like we're coloring something either red or blue, depending on which way the flow is going, but the shading of that, maybe becomes more important with when we're measuring stiffness or when we're measuring, uptake of certain radio tracers or what have you. The varying ambient light, this is something where, everyone has been through this, where the one reading room is brighter than another. If you try to take the same display out into the environment in the hallway or the exam room, then of course it can look very different, and what you can see still on it may change. The viewing angle of displays is something that needs to be controlled, in particular how the curve of the gray shades change with the viewing angle. And then of course the stability of that curve, do we have, if we have black and white, do we have everything staying the same between them? So these are some of the challenges, and the solution, that I think that most people have come up with is there needs to be sensors in the display. They need to look at themselves and say, okay, what's going on? How do I need to compensate for this? And that's used for the continuous, adaptation, but also as a check to see when is it getting so that it can no longer hold what is the level that was set that we want to keep stable. The uniform luminance technology, this is the thing that gives you that corner to corner sameness for images, and it's akin to what's done with flat fielding the detectors, where they'll measure what the detector elements see, and then they'll do a gain correction. In our case, it's a separate curve for each part of the screen, or on some of the models for each pixel, so that we can have that DICOM accuracy everywhere equally. And then to compensate for the ambient light, there's a scheme where this is taken into account for the DICOM calibration. And then the other piece that we find that we recommend to people is it's good to get a complete system. It's good to take the whole imaging chain and put together pieces that were all designed to work together, for the whole lifetime, in order that one piece doesn't become the weak link, even while the display itself might still be stabilized. So those are some of the things that are done to solve it in a general way. And then if we look at back to this concept of teasing these two populations, apart a little bit, there are some things that make a difference. And one of them is, how efficient can people work, right? Because if people can work efficiently, they also tend to do, a better job. And one thing that helps is to have, enough of your field of vision be filled with the picture. So if you have a little tiny display, it's very hard to, get your work done efficiently. And one of the things that we found specifically for breast imaging was the aspect ratio of the display needed to be taller than what it was originally. So originally it was a 4:5 aspect ratio. And what we found was that a taller 3:4 aspect ratio made better use of the space. So that has two things. One, when there's an image that's been scaled to the screen, you're using more of the screen. You don't have a big blank space on the right or the left. But also it's more likely that an image will be able to fit on the screen because we've added additional pixels in the vertical direction. So it's less likely that we're going to need another step when you're looking at the images one-to-one. So that's the field of vision aspect. The calibrated color, we can measure what people can see, how many shades of color people can see. And it turns out that if you calibrate the colors analogously to what's done with DICOM and spreading out the gray shades so that people can see the most shades, you can also get a substantial increase in how many different colors people can see, in the images. The brightness has a big impact, and I'll talk about that more in a moment. But it basically, with the technology where you can boost the luminance, as well as just starting fundamentally from a higher luminance, it increases the probability of detection of small objects like microcalcifications. And then specific to the modalities where people are going to cine through things, the moving images become, it becomes easier to see small things in those images when the display is designed to be able to switch from one frame to another very quickly. And I'll cover those last two items in a little bit more detail. So if we look at the breast tomosynthesis studies, there's, it's a multi-frame stack of images, right? And the fact that people are going to cine through it means that potentially each frame is only visible for a short period of time. And the liquid crystal display, the response of that is going to determine how clear is the next image, right? So if the next image has to take a while to reach its level for all the pixel values, and in fact you're already moving on, then you may not get the full impact on your eye of the image that's appearing there. And when we talk about LCD response time, you would think that this would just get better over time, right? That the displays that were introduced in 2004, that they would have one speed, and then a few years later it would be faster and faster and faster. But actually, recently, there are quite a few displays that have been introduced where, in order to make the contrast higher between the black and the white, they've said, well, let's not worry about the response time. And so they actually take a lot longer to switch from one value to the next, or one frame in the breast tomosynthesis stack to another. So this, of course, is going to have an adverse effect on the detecting things that appear. And it also means that people are going to tend to slow down because they will say, oh, I need to make sure I'm seeing the things that are there. So these are, let's say, challenges. And if we look at the, the subtle details that we have in this. So here's a cine. I don't know how well the actual cine of this appears coming across Zoom, but the image on the left, it changes. And then if we just, look at this, holding still for a moment, there are some, let's say details, maybe some small calcifications that are only present for a few frames. And I think the other thing that people would be familiar with is the fact that some of the calcifications are in one frame and some of them are in the next frame. And it's only by watching sort of the cine go by that we appreciate the three-dimensional, arrangement of them. But these subtle things that are only there for a short period of time, they're potentially going to get blurred by the cine. And so this is a little chart showing if you're going from one pixel value on the right to the new pixel value on the left axis, how long is it going to take for you to get there, during the, which is in the vertical axis. And for some transitions, like from 550 to 200, it might be very short. But for other transitions, it might be long. And that's really the problem, is that some of these things will make it harder for people to see. So what we have done is we've said, okay, akin to what was done for the luminance uniformity, we can also measure this and make the transition from one pixel value to another more uniform. And I know some of my colleagues refer to this as temporal uniformity. It's really about making the response time uniform and short. That gets us the advantage in conspicuity. And so here's an example from a study that was done when we had first developed this technology. And at if you're flipping through things at 25 slices a second, you had a 10% higher area under the ROC curve, that was versus if you just used a 2D display that wasn't designed for the cine. And this was statistically significant. And this was, these results were basically told us, oh yeah, well then we definitely have to put this in the products in any cases where the display is not natively fast enough, or where we want to get the last little bit of conspicuity for these small objects. So maybe an experience from Dr. Perez, and he was talking about how we know what we can see, but importantly, we don't know what we don't see, right? If we don't see it, then we don't actually know that it wasn't there. I mean, it's just, we don't even think about it. And so his remark was that it's not a question of the radiologist's capability, it's the screen that we're looking at that doesn't show us something, and that's why it's important to have the best technology. And so that's really always been, what we're trying to do is make it be that at least if it's in any way possible to make it visible, we should make it visible so that people have an opportunity to see it. All right, and then on the high luminance, this is the other thing that I wanted to talk about. So luminance has an enormous impact on what we can see. And, just as an example, if I put something up, at, here's a picture at one brightness level, and here's the same data, but presented at a higher luminance level, where it appears to be twice as bright. And I think you can appreciate, even though this has gone, from my computer to Zoom to your computer, I think you can appreciate that in the first image down below, it is clear that there are, calcifications in that image, and it's not like someone necessarily would miss that they're there. But in the upper image, it's just a lot quicker to see them, and it's a lot easier to appreciate their extent and the shape of them with more luminance. So this is I think something that people have known for a long time. And if you look at the light boxes for mammography exams, those were typically brighter than the ones used for chest films. And in fact, when we got going in the space of making workstation displays for mammography, we measured how much light is coming through the mammography films from those brighter light boxes, and we found out that the white level was about 1,000 nit, about 1,000 candelas per meter squared. And we said, oh, okay, then probably it would be good to make the displays at least that bright, so that people can see similarly very small things. And so that's where that came from. And so if we look at the displays that were typically used for general radiology, those were set about 500 nit. And then when we introduced something for tomosynthesis, we said, okay, that one will be at 1,000. And then we even added the feature of, we call it illuminate, but it's basically a hot light that will boost up an additional factor or two that people can do so that they can see the subtle details more easily. And that turns out to have a fairly big impact on how small a thing you can see and how well you can perceive the morphology of, let's say, calcifications. So here's an example from Dr. Alejandra Fuentes. So what she's talking about is exactly this, right? If you've got low density calcifications, something that's not just jumping out, by running all the way up to full white, and even if they're not visible on some other displays, you can see them perfectly well if you have something that's designed for this. And there she's looking for the distribution, the borders, the density of the calcifications to help her determine, is this a relatively benign process, or is this evidence of disease? So I think that improved acuity when evaluating these microcalcs is important. The same thing applies to speculations. I think there's been less work done to try to characterize how well you see an individual, ray off of a speculated mass or something. But there has been some work done with speculated masses versus non-speculated masses that similarly show an advantage to having a higher luminance. All right, if I now move on to talking about the home office. And really, the home office is not fundamentally different from a remote office, right? I mean, once you say that it's not in the hospital with the same, in the same suite as the X-ray machine, you're talking about something where the images are going to go from one place to another place, and someone's going to work in that other place, and then they're going to work on the workstation and read them. So it's not, home office is not really fundamentally different than just a satellite, facility where we're transferring images back and forth. But it is actually someone's home, so there are some considerations. An example, that we have is when the Department of Veterans Affairs in 2020, they wanted to right away switch everybody to home reading, or as many people as they possibly could, to minimize the number of people who were coming into the facility during COVID. And so they put out a challenge to say, could somebody set up 400 home workstations for radiologists and have those actually be properly managed under a QA program, deployed and set up in 30 days. And yes, this was achieved. So it was possible to do this, by standardizing on a single model, and then using the quality assurance software that is cloud-based. We were able to hook all these things up, and so it is possible. And I would say one of the key things here was that they went with something that was proven. They didn't say, why don't we have 400 different people try different things and see which ones work, because that would not have gotten them up and running in 30 days. So one of the things that we always counsel people to do is plan the systems for trouble-free installation, and it's not that hard. It's basically just make sure that the components that you're going to be putting together are they're pre-tested as far as their compatibility goes. And so to this end, there's a couple of things. I show a picture there on the left of someone using a external graphics box, with the displays, and then that hooks up to their laptop. So this is one of the things that people have adopted, is they want to be able to bring their laptop in and out of the healthcare facility, and they don't always necessarily need to be reading images on a diagnostic monitor to get some of their work done. But when they do, they can sit down their laptop and hook up to something which basically is going to act the same as the graphics card and that would be in the computer, and the displays that would be in their regular office. So that's one example of something where the particular laptop models are validated with the external graphics box, with the graphics card, with the displays. That sort of thing is sort of a complete solution. And then on the right, I'm not going to go through this, but it's an example of a workstation compatibility matrix where the different models of workstations of various sizes, right? Some are large, some are small. Some take only a very small graphics card, some can hold a great big one, lots of disks and stuff. But we'll check all of these, models of the workstation computers with the various graphics cards, and the operating system version and such, and then say, oh, okay, these worked. Or importantly, there were ones that we had to leave off because they, didn't work for some reason. And then there's a few that, basically have some notes that say, well, it will work, but only if you plug it in this slot versus that slot, or you have to, make sure you have a system BIOS at least this level or what have you. But the idea of having this all done ahead of time means it's easier for people to see. So now let's turn to quality assurance. And I think one of the things that people are noticing more and more is that the standalone workstation for digital mammography or breast tomosynthesis, that is, let's say, that work is also being done, or increasingly being done, on a multimodality PACS workstation setup that isn't necessarily something that someone said, well, and the main thing for this is going to be mammo, or the main reason we chose this configuration is going to be mammography. And this has, some impact on the responsibility for the quality assurance, because in mammography, you have to do the quality assurance. It's a good idea to do the quality assurance on all the systems that are used in radiology. In some states, it very much is. But in other places, this is something that people look at and go, well, that's just for the mammography people. But anyway, it means as it shifts to the multimodality PACS, that it gets integrated into however they were doing everything else. And all of a sudden, some people are discovering that they're now part of the mammo QA team, where they hadn't been before when it was standalone workstations. I'll say this about the standalone workstations. and you see she's using a gray one on the left. There's still a lot of gray imaging, and they're particularly for screening mammography. This doesn't come in color, and if people are just using just looking at X-ray mammography or even tomosynthesis, a good grayscale monitor is still useful if they're spending 2 days at home doing that, and then they're coming in and doing interventional multimodality cases, in the imaging center the other 2 days. And so we do know some people who get a very nice set of grayscale displays just for the home, just because they're going to, in a dedicated way, use that for the screening, and they're not going to be looking at the ultrasound or the MR or what have you. I wouldn't say it's the majority, but it is something that does happen, and consequently their grayscale displays will probably continue to exist. Back to QA. The motivation for having a well-defined QA policy is, well, that it's required by the FDA. And they say that the facility has to have their systems comply with something that's substantially the same as what's recommended by the image receptor manufacturer. And so if there is a workstation QC manual, and that's, then that is substantially the same and people can follow that. And the QC program then has to be, implemented, let's say, in the organization, and it's also being done under the guidance of a medical physicist. So then everybody submits documentation for the compliance as part of their accreditation, but also there's going to be an annual inspection and review of this. And so that's really something where it's taken quite seriously. And in fact, there's a number of people who are responsible, to the point of actually signing their name to this, that it's being done correctly. So this is, I think, sufficient motivation for the QA policy. And what we've tried to do is make this as simple as possible. So you really have like a single click thing you can push to say, like, okay, give me a report, show me that it's in compliance, show me that all of the tests that were supposed to be done have been done, and you get something that can then be, a PDF that can be printed out and put in the binder and shown at the annual audit. So that's really how we see this. And the other half of it, back on the hardware side, is what do you get with the automatic sensors? So we talked about putting these in for the motivation of making the image quality better, but you also have a situation where if you don't have the automatic sensors, or you do have the automatic sensors, you're actually going to have quite a different experience in terms of how much work it is to do this. So if the display is easy to clean, then that's going to save you some time. If the visual conditions are something that can be checked remotely, and then there could be a notification, that's easier than if you have to look at them, every day by by a person. If the image quality check is something that takes 15 minutes for someone to hold a photometer up on things and make measurements, as opposed to there's a built-in photometer that does this automatically, that's also going to be a time saving. And then similarly, there are things that happen at an annual period, although most of those will land on the medical physicist. So this part too is something that can really make a difference when you move systems into the home, because it may have been the case that the staff person was not as, their time wasn't quite in as short supply as the radiologist themselves, but now that it's moved into the radiologist's home, it is the radiologist themselves that's going to have to do any of these extra things. So that's an additional motivation now to minimize how much work has to be done for this. So if we look, and I will admit this is a completely commercial slide because it mentions the product QA Web. But if we look at it from the motivation of what the cloud-based QA gets us, then it's really that you don't have any extra hardware on site. It's independent of the network type. You can, however you get your network, in or out, with or without VPN or whatever, can work. And it has customizable policies that can be deployed remotely and across groups of systems. And then it's been designed with modern security, complying with European and US, etc. Security things. So that's the advantages of the cloud-based system as opposed to something that has to be maintained locally. So that is the end of my talk, and then we'll see if there are any questions.
All right, thank you so much. That was great information. It does look like we have one question. So does Barco also have different form factor for monitor stands for home workstations? In the ever-changing home reading arena, we have found that office space at home is a huge factor in the monitor considerations.
So yes, so we have the Coronis Unity, which is very large, and indeed there are places where that might be very inconvenient to put on a narrow desk. It's possible to use a pair of the 5.8 megapixel displays and tip those, so that you aim the pair of them, at the viewer. So those are a little bit smaller and individually definitely lighter and easier to set up. I hope that's the question that was being asked. There are a very small number of people who use the displays in landscape mode and look at breast images, what I would think of as sideways, but I don't think that's probably what you're talking about.
I think that's about what they were looking for. So great. All right, so looking over at the Q&A window, let's see. One other question. MQSA inspectors check home monitors too. This is done yearly. What is the best easy way to print 1 year of report for remote monitors? And would that be included in the daily QC?
So the daily QC is not recorded in the system. We provide a paper form that someone can tick off, initial when they check that the room is okay. What a number of people are increasingly doing is using the newer software Enterprise and turning on the ambient light check that then would replace the need for someone to look at the ambient light in the room and go, this is more or less what it was when the physicist was here. And so with that, and that uses the ambient light sensor that's on the displays. Now, not everybody has an ambient light sensor on their display. It wasn't part of all models that we ever made. I think probably the majority, certainly, of people have a system, and certainly if you bought something new, it would have the ambient light sensor. And with that, it can be set basically to look and see, and if the ambient light is higher than what was defined as the reading room, then, and it like that way for 30 seconds or something, then it will actually pop up something interrupting people's work, and say, hey, your ambient light is higher than what it's supposed to be. And then the person can dismiss that if, basically if they are going to be changing the ambient light so that it's correct, it won't bother them again, or it'll pop up again then. And so some people have moved to that to prevent having to have a sheet where they initial, that it was okay today. So that's one way to do the ambient light, the daily QC part. And then as regards the report in Enterprise, the one-click report that I was flashing up there, that shows the constancy checks that have been done going back in time. So that gives you, if you did it at the end of the year, or at the it would go back into the past.
Those sounds like some great features. One other question, does Barco have integration with PACS to allow auto luminance control based on the modality being viewed to better increase lifetime of the monitors instead of running the monitor at a high luminance all the time?
So most sites, particularly mammography, but I would say this applies also to radiology, they are only comfortable with having the display calibrated, meaning that there's some particular way that the display itself is running. And it is possible to, for example, push a button on the display or whatever and get it to dim itself. But then you end up in a situation where that level wasn't itself being controlled the same way that the calibrated luminance was. So what we have is something that solves the same problem, where someone may be bringing up a nuke med exam with, it's basically black dots on a white background, and there's so much white on the screen that there's no way they want that displayed or need to have that displayed at 1000 nit. And so we have something where you can leave the display calibrated at 1000, but darken the appearance of that application to any reasonable level. Like you could knock it down to a quarter of its luminance, if necessary. We set a lower limit just to prevent that people can create something where it's, it would be very likely they would have trouble seeing, certain things that they need to see. But that's usually enough to be able to knock it down by that much. So in that case, the display is running in its calibrated state, and the application is darker, and that can be toggled. That can be set to a hotkey that the person wants. If they're using one of our touchpads, it can be hooked up to one of the buttons on the touchpad or a gesture on the touchpad. And then in terms of the lifetime, I think one of the things is that with all of the displays that have been manufactured in recent years, they are all engineered to go for many years without wearing out when they're run at the calibrated, the typical calibrated luminance. So even if someone wanted to have a display that was running at 1000 because that was its default, that would be just fine. It'll hold that for many years. In terms of if someone wanted to know how long, we warranty all our products for 5 years, and then you can get an extra couple of years if you want as an additional item to add. But they really goes back to when we were first designing the breast imaging displays, that we went around and asked people, how long do you expect this to last? And they said basically as long as the modality equipment, which we determined was between 7 and 11 years. So the design target is to go for even longer than the warranty period. And that's without any, trying to reduce the luminance.
Great. All right, and it looks like we have time for one more question here. So will Barcode Builder help us build custom reports off QA Web to meet the MQSA requirements?
So this is a great question. There in enterprise, there is a way to look at what is coming, to see the features that are being developed for the next release. Also, historically, you can see what was implemented in different versions. But I think my favorite part about that is that same section contains a suggestion area where people can make a suggestion, they can vote up suggestions, and I will say that the developers see that directly, as well as the management. And it's very relevant who's making the suggestion. In other words, if it's a doctor or an administrator who's taking care of the site, who's making this suggestion, then that's going to be taken very seriously, because that's the customer. And so that has been used, and you can look back in time and you can see the suggested things that were acted on. That's a very good way to give specific suggestion for how it should work, because I think that's part of it with all software things. It's easy to say, oh, this should be better, but the credit really goes to the person who says it should be better because it should work like this, and then they spell out exactly how they want it to look. So I look forward to seeing the details of the suggestion.
Right. That is a great way to leverage crowdsourcing feedback for immediate, changes. So I love that. All right. So with that said, we are coming to the top of the hour. Once again, Albert, thank you so much for your time today. This was such great information for our audience, and I know that they'll take it and use it in their daily workflows. All right, so wanted to just remind everybody, for those of you looking for, additional guidance in mammography, SIIM, ACR, and AAPM have just released our recent practice parameter for determinants of image quality in mammography. So visit the SIIM website and find the practice guidelines underneath our resources for more information. Also, don't forget, we have a couple additional upcoming webinars. In the month of November, we have 2 webinars that are focused on enterprise imaging. And in December, we have the SIIM 23 call for abstracts, research applied informatics, and our session proposals coming due. Once again, as a reminder, SIIM members who look to receive their IIP credits, these will be published directly in your SIIMU account in the coming days. If you are a SIIM member and want your credits to be automatically transferred to the ABBY, which we will do quarterly, be sure when you renew your membership this month to add your full date of birth and your ABBY ID to your membership profile. This will help us more easily transfer those credits, and so you no longer have to do so manually on your own. And once again, we always love to have feedback. Please help us plan. At the close of this webinar, there'll be a button that takes you to the survey. It'll be at the top of the webinar page. And finally, last but not least, thank you once again to Barco for their sponsorship of the SIIM 2022 EI webinar series. We look to see you next month. Have a great day. And thank you once again, Albert.
Thank you all.